my screen. Okay, can you please tell me what screen are you seeing?
I can see the presenter mode.
Okay. Where is that to switch? Okay, here it is. Okay, now I hope
Now I
you
can see the right screen.
Okay, so thank you. Hi, everyone. My name is Carolina Mendoza-Puccini. My pronouns are she, her. I'm a program director at NINDS, and I manage the Common Data Elements project. So I'm going to give you a very quick and brief overview, hopefully understandable, of what are common data elements. So we have, this is our website, our email. Before I start, I encourage you, if at the end you don't have questions or questions come up after the presentation, feel free to contact me. This is my email, or contact my project through our website. There's a contact us there. But I encourage you to go there and look at the CDs and contact me anytime. Okay, so a little bit of background of the common data elements. These NINDS project was created back in 2009. We started with 8 disease areas. Back in 2009, the field of CDs was very unexplored, unknown, and it was like just starting. So we didn't know a lot of things. We were the first NIH institute that developed data standards, and this project is a trans NIH effort. We also work with other federal agencies, nonprofit organizations, academic institutions, professional organizations, and also patients. So what is a common data element? Common data elements is a fixed representation of a variable, and it comprises one defined question. For example, how old are you, if you're asking the patient directly? That is the common data element, is that unit question. And that common data element, or that name, for example, age, will be paired with a set of allowable answers. So that's how we tell people, okay, you're going to collect, if we're asking how old are you, we're going to collect that how. Is it going to be an open text, which is not recommendable? Or are we doing ranges, like intervals from 1 to 10, 11 to 20, and so on? Or we're doing months if it's a child, or days if it's a newborn, etc., and so on. So all these variables paired with questions are going to be used across multiple sites, studies, data sets, and that's why we're calling them common. So the benefits of using data standards or common data elements, or using the same way of collecting data, have many benefits. And in terms of this particular NINDS project, it's an open access project. That means that anyone can go to the website and download case report forms, data dictionaries, if they're not copyrighted. That's the only caveat. So if we have validated instruments that are copyrighted, you will find a document that is called Notice of Copyright, or Instrument Information, where it tells you everything about that instrument, from where to find it. So there's a link to the place that holds or owns the copyright. It has a brief summary of what is the instrument, the benefits. I think it has a little bit of how is it scored, etc. Like general information is very helpful. I used CDs in the past before I came to NIH, so that was a very important document. So the CDs can also be expressed in machine readable formats. They will allow you to link data sets and examine relationships in an easier and more efficient way. And they will increase precision because it's going to minimize the variability and improve the efficiency, as I said, because it's a streamlined process. The CDs promote interoperability. As I said, it's easier if you have, 2 data sets that are collecting the data and they have the same variables in the same way, just to, analyze them with minimal curation. And then, it will be easier to do reanalysis, meta-analysis, and also to collaborate with other people. In terms of using exactly the same common data elements, now we have the technology to do mapping. So I would tell people, yes, we at NINDS, if it's an NINDS funded trial, we prefer that you use our CDs. But if we don't have those CDs, you can reuse from other projects. Or maybe, we can talk to me or the program officer and agree on something that makes sense, that is mappable, for example. Then it will improve, sorry, tongue-tied. It will also improve your quality. So at the end, your most and more valuable thing are your data. And you want a good quality data. So data integrity will be better if you use a harmonized way in collecting your data. Also, it will promote reproducibility, efficiency of collection, efficiency of use, as I mentioned earlier. And also, if you're putting together an application for NIH, you will see that CDs are mentioned in the data management and sharing policy. So it will also add some value, if you're using those data standards. So how do we develop CDs? And this is specific to NINDS. You may find similar processes elsewhere, but this is specific to the project. So we identify the CDs in different ways. We either have nominations from the community, congressionally mandated, or like a mission critical gap that we have to fill in a disease. For example, COVID was one big one. As soon as the COVID pandemic started and we needed to collect data in like large number of data, we needed a standardized way of collecting data. So we developed CDs, and this was an NIH effort. As I mentioned before, this is a collaborative involvement with very different entities at NIH, other federal agencies, National Library of Medicine, CDC, DOD, and nonprofits, academia, etc. And as I mentioned before, we try to align with international data standards. We try not to reinvent the wheel. So one of the things that are important when you're collecting data or talking about data is the FAIR principle. So it's findable, accessible, interoperable, and reusable. So that R of reusable, we try to look at CDs that have been already developed, and then we reuse them as much as we can. And then NINDS, this group of people are leaders in their field of every single neurological disorder. These are external members, plus what I mentioned before of some NIH, etc. So NINDS, we provide a continuous oversight, but the decision of what they select as CDs is like an independent decision on, guiding by us, making sure that they don't deviate from our own goal, but it's made by the group. So this is a website. We have a way for the scientific community to nominate CDs. So we have some limitations in terms of budget, the contract, but we try to always take into account what the scientific community needs. So this is the link, and this is a QR code here if you're interested in nominating something. And as I said before, contact me if you have questions. So this is the CD project at NINDS. So we start with inviting the working group members and, based on their expertise. And then I'm not going to go through the whole process, but we have internal meetings, which takes most of the time here in the 6 to 9 months, the meeting subgroups. Then we do an internal review. Then we go to a public review, incorporate those changes or those recommendations, and then we post them on our website. And in total, it's approximately 18 months, the whole process. So it's a lengthy process. So this is a CD classification for the NINDS project. And don't worry if, this is, for me, it took me a while to really grasp and understand this. I don't think right now it's so important for you to know it, but I'm going to mention on why, like what is the rationale? Why are we collecting things in the way we do? So we classify our common data elements in general core. So these are elements that are disease agnostic, like demographics, social determinants of health, some social determinants of health, Then we have the disease score that are going to be common data elements that will be collected across domains within a disorder. For example, for stroke, we cannot tell everyone to collect, I don't know, like biosamples or cognitive or certain images to all and every single stroke trial. That is not the goal. We have like a set core of CDs, which is a short list that will apply to every single study and trial in stroke or in that particular disease area. So when we talk about core is for NINDS funded trials, is what we tell people, this is what you should collect at a minimum when you're doing research in stroke, Huntington, etc. And then the rest are recommendations like supplement are highly recommended. So if you're doing something like you're doing a study or trial in stroke and you're collecting, you're focusing on cognition, then there's a list that these experts determine that you should use, like certain instruments, certain data that are important in that particular subdomain. And there's a comprehensive list of everything from imaging, patient reported outcomes, etc. Then and these supplements are highly recommended is where most of the CDs are housed. Then we have the supplemental, which are instruments that, and sorry, let me go back, just to tell you a bit more. Supplemental highly recommended are usually instruments that are widely used, recognized in the scientific community in that particular area. They're validated. So it's like, let's say the MOCA for cognition in stroke, and I'm mentioning cognition a lot because that's my background. So those are instruments that are very commonly used in the scientific community. Then we have the supplemental. The supplemental are instruments that are also validated. However, they're not that widely used. They may be specific to certain populations, to certain subdomains of that disorder, but they're still validated. Then we have the exploratory. We don't work a lot in the exploratory because they're not validated. So they're either not validated for that particular disorder or not validated at all. So those are simply lately in the most recently developed and revised projects, we've been putting them in a list. So there's like this is a list of interest of instruments that you may be able to use, and because there's nothing else for that particular disorder testing what you want to test. If you want to use an instrument validated for Parkinson in another disorder, but it hasn't validated in your disorder, but you're interested in collecting that data and maybe validating that for that disorder. So that's something to keep in mind. But these are not like our main bulk of the CDs that we have. And that's not really reflected in the size of the pyramid. So just take that in mind. For traumatic brain injury, we have a slightly different classification. We're currently revising that, so I'm not going to talk about that now. So this is the list of all the disorders that we have already developed. The ones that have a red star have a pediatric CDEs. And then we are currently working, we recently published the Parkinson last year. It's a revised version. It has a beautiful digital technology group with very good guidance on that area. And then we're currently working on mitochondrial disease. And we have from very common disorders like stroke, TBI, Parkinson's, etc., epilepsy. And we also have rare diseases. We have some neuromuscular diseases, Huntington, Friedreich's, etc. And then if you have, another recommendation, there's a website that I mentioned before. So this is our governance. We have a general group that oversees the whole project that is called the steering committee. Then we have under that the working group oversight committees that provide oversight to the working group. So the working group is Parkinson, every neurological disorder, or one group that we have that spans across many disorders, that it is the neurological rehabilitation group. So under that working group are the subgroups. So those are the different like biomarkers, patient-reported outcomes, etc. And then every subgroup has a chair. And every subgroup is comprised of a chair and or more than one chair and the working group members. So this is our website. There's a QR code here, and Courtney will share the slides after the presentation. So some things to consider about using data standards. And if you've never heard of data standards, don't worry, you're not alone. Some and many people haven't. However, you may be using, I'm 100% sure, some type of standardization among your trials, maybe at your center level, your lab level, or maybe in collaboration with other groups. But this is like a higher level commonality. So to use CDs in this way, like using well-established CDs that have been used by thousands of people, there's a learning curve. I'm not even telling you, you understand everything I'm saying here if you've never heard about it, or if you don't have a deep understanding of this topic. So I think the bottom line is, yes, it may be a little difficult. It takes some time to learn it, but once you learn it, it's not that complicated. So it's important to coordinate to avoid duplication of efforts. So that's why it doesn't make sense that there are like 100 different labs using 100 different ways of collecting data. And other thing to take into account is sometimes it's hard to retrofit or map that existing data to new CDs if you want to go back. And yes, that takes a lot of effort. I'm not going to lie to you. But at the end, if you want to be able to collaborate with other larger groups, compare data, it's worth doing the work because it will stay there forever in a standardized way. And if you are starting a new project, the best thing to do is to plan from the very beginning. If you are doing an NIH-funded application, that is the time to start, to talk to your program officer, talk to me, or to any of the projects that are across NIH that use CDs. Okay, implementing a CD initiative. So what will be the thought process of, okay, I'm gonna use CDs, or I'm not sure, what should I do? So first, as I mentioned before, decide early. What are the CDs that you're going to use and why? And here I'm not talking about only NIH funded. CDs can be used and are actually required in many like funding institutions or federal funding institutions. So it can be NIH, FDA, like the American College for Cardiology, and I think the American Academy of Cerebral Palsy, they require them or they recommend to use CDs. So the first thing to do is talk to that funding agency and make sure that the CDs that you're selecting are appropriate. Then what are the CDs that you're going to use? I would say try to go to a reputable and known group that are developing CDs. NIH is one, CDC, FDA, also CDs that have a broader community engaged. If you are developing CDs or looking for existing CDs, make sure that to use those that have the community engaged, like the buy-in from the scientific community. So don't go to like very small groups that are developing CDs unless that's the only group developing CDs, like the preclinical. That's a very specific example. So try to use something that have been used by many other people. And then, endorse and require CD use. Same thing, choose CDs that are endorsed by that organization if they have that, if it's mandatory, and how to do the compliance that is, or how they monitor that you use those CDs in a proper way. So this chart here is a little outdated. because it's up to 2018. I need to tell my NLM colleagues to give me the updated version, because there was a huge increase here after the pandemic. And that was COVID-19 who really highlighted the need of harmonizing data collection. So this is, I'm talking about this year, like the pandemic really accelerated the use and highlighted the importance of using these data standards. So this is just a short list. Maybe I'm missing some projects across NIH of all the projects that either developed, shared CDs or reused CDs from other projects. And here highlighted, we have one from NINDS that is still ongoing, and it's the NINDS COVID-19 Neurobiobank. So they're collecting both data and biosamples of patients diagnosed with COVID-19 that developed neurological complications or worsening of underlying neurological complications. So this is an example of some language, and that's why I encourage you, again, that has nothing to do with CDs, to make sure that you're responding appropriately to your funding announcement. So go with a magnifier and read every single part and make sure that, if they mention CDs, and this is an example of NINDS announcements mentioning the use of CDs. So here, this is one of the siren actually announcements. So we but we highly encourage people to use the NINDS CDs. And then part of the review process also is the question is if the applicant is considering using NINDS CDs, and or the proposal is appropriate. This is probably not super updated list of trials that have used or are currently using common data elements. So in StrokeNet, we have more trials that I need to update here. Most of these are already in our archive data repositories or accessible. You can request that data. NeuroNext, these are also some examples. They're not all here. And then NET, which was the Siren predecessor. These are all in our archive data set already. And Siren, which is one of the newest networks, have these trials are all ongoing. The pediatric ISCAP, HOBIT, Boost 3, and then we have some of the ancillary studies, R01s from these trials. And we have, I think, other trials from Siren. I see C3P, I don't know, it's a COVID trial with plasma. Also use CDs. Then our intramural also uses common data elements. So you've heard all the beautiful things about CDs, and I understand that these, CDs are not perfect. And however, you have to put everything in a balance. They have more benefits than limitations. So this is the list of limitations. So one is that many groups are developing CDs, so there's a lack of consensus. So you may find, like 50 different ways of collecting education, age, race, ethnicity, etc. However, now with the new technology and, with data science, it's easier to map those CDs. So I'm not super concerned like I was many years ago in having the exact CDs, but also, if you're using different CDs, just take into account that you may lose some data. So that's something to take in account, and harmonization of large data sets take a lot of time and funds. Then also the copyrighted instruments, it's not maybe expensive, they're expensive. So you have to, we understand that, but however, sometimes the gold standard for that particular area that you want to test is copyrighted. So we're limited in that selection. So also there's variable validity in different populations, depending on, what you're using and what you're studying. It may not be appropriate for non-clinical trials, like for observational, but it's not always the case. We have large epi studies that have used CDs without any challenges. Also, in terms of preclinical, because I talked about clinical only, preclinical CDs are very scarce, or I don't think there any or very little. There's no consensus in how to collect data. So we're also working in that at NINDS. And also there may be a variability in interpretation and implementation of these CDs. So that's why, for this project, we don't only offer case report forms or just, data collection forms. We also offer guidance. We have guidance document in every single project, in every single domain. So there's a rationale on how we're collecting the data, how you have to collect the data, and why. Yeah, so there's a lot of information in addition of only, data forms. So then this is just unrelated to my presentation, but just FYI, NINDS is hiring. So if you want to join us, you can explore our openings. And then I will close here. And thank you very much. And I see here a question. Let me start with this one, but I'm open to questions. So any open data sets on NINDS CDs on Guillain-Barré? I don't think we have any on our current the archive data sets, and I can share that information, the link of what we have, but I don't think we have any Guillain-Barré. However, you may find it elsewhere. I can also share the link that I'm going to share has in the bottom a list where you can go to other NIH funded data sets. Okay, any other questions?
I don't see anything in the chat, and I don't see any hands raised.
Okay.
So if any questions do come up, please feel free to put them in the chat.
Yeah. Okay. I'll stay online to answer any questions, or just feel free to email me anytime. Thank you.
Thank you so much. And with that, I will hand the screen over to Dr. Benson.
Great. Thank you, Courtney. And thank you, Carolina, for that presentation. So someone let me know if you can see my slides.
I can see your slides.
And I should be, says it's paused. I'm trying to get it to, okay, good. There we are. Okay. Very good. So I'm excited to present to you today. This is probably my second or third time or year sort of presenting to you. And so I know we probably have a lot of new people participating here. So hopefully if there's anyone that heard my presentation before, I've tried to change this some to make it interesting. And this is sort of a teaser because Dr. Cherise Sankor from my office will be presenting to you all in June in person. She's going to be coming up to Ann Arbor to present. And so some of this, as you know, that the mission of the NINDS is to seek fundamental knowledge about the brain and nervous system and to use that knowledge to reduce the burden of neurological disease for all. And that includes all race, demographic, sexual gender minorities, everyone. And we do that by the strategies that are listed here on this particular slide. My office in particular, the NINDS Office of Global Health and Health Disparities, we lead the coordination and development of programs and initiatives that foster national and international research on disparities and inequities in neurological diseases. We do a lot of work with low and middle income countries. We do bilateral partnerships with high income countries. And then we do special programs as well that we create, or special initiatives to address special needs within the United States. And so the populations that we deal with are those populations defined by the NIH to experience health disparities, and that includes race and ethnic, minoritized populations, people who live in rural areas, sexual gender minority, socioeconomically disadvantaged populations. And we're starting to look at intersectionality as it relates to disabled populations as well. And so we do a lot of congressional reporting and other things related to that as well. Over the last 2 to 2.5 years, we've been doing a strategic planning process for health equity. And this process, the results of this process is what we're going to start implementing and what we have started to implement to focus our investments related to health equity for the next 5 to 10 years. During our planning phase, we had a working group of our National Advisory Council that was put together with over 30 experts that worked on that. We looked at the one report that was done previously in 2011, and that was the first time that this was done, where we put together a panel to look at health equity and neurological disorders. We had a trans NIH work group. We had a group, or we still have a group of NINDS extramural staff who did a portfolio analysis, and we looked at what we funded related to health equity from 2016 to 2020. We currently meet as well, and we invite outside speakers. We review journal articles, we review initiatives. And so we do a lot of different work related to health equity. We had a request for information, a workshop that's actually, it can be viewed online through our video cast as well. Excellent if you have a chance to see it, and you can get that up from our website. And we have a series of 10 manuscripts that will be published in Neurology in August of this year, open access. And it actually outlines the whole process, the background for what we're doing. It has the recommendations and everything. And it's very instructional in terms of what investigators that are interested in doing health equity research should do or consider in terms of their research projects. I list here a slide of the people that were on our National Advisory Council work group, and I'm sure some of these faces are familiar to you. And so I list here sort of the goals of this, of the planning process and what we asked the working group to do. And so we use, just to define a couple of things, we use the Healthy People 2030 definition of health equity. This slide just sort of lists the, I mentioned this earlier, the populations designated by the NIH to experience health disparities, and I have the groups listed here. And the intersectionality is something that's very important as well. And I mentioned that particularly, you know, when it thinks, we have to think of this in general with all of the groups, but also I mentioned disabled as well. And so these are some of the topics. But this is sort of the definition that we use for health equity, the attainment of the highest level of health for all people. And this requires valuing everyone equally with focused and ongoing societal efforts to address avoidable inequalities, historical and contemporary injustices, and the elimination of health disparity, health and healthcare disparities as well. And we have a link to that here. This slide is I like this, and I present it because it's a wheel of power and privilege. And when you think about that, if you consider sort of power at the center, and you think in terms of all of these factors, in terms of what is more highly linked to power, a lot of people and populations and groups of people are marginalized. When you think of people that are poor or homeless, or from certain race ethnic groups, or not your typical cisgender people as well, then you sort of move away from that center of power as well. And so we want to, again, coming back to the mission of the NINDS, make sure that we address the burden of neurological disease for all people. And so we try to do things to make sure that we're doing it in an equitable fashion. And just, I'm only going to highlight this today as sort of a teaser. I'm not going to go into everything that we did because it's a lot of stuff. And so these are just the titles of the 10 manuscripts that will be published here. And I'm just going to focus on a couple. And then at the end, I'm going to talk about one of our novel targeted public health campaigns that the NINDS is doing now. And it's targeted So one of the publications actually was a mortality analysis. And so we asked the question, how many US deaths from neurological disease would have been averted had non-Hispanic Black Americans experienced the same mortality rates as non-Hispanic white Americans? And so we used for this particular study death counts from the CDC from 2010 to 2019, and we used ICD-10 codes for neurological disorders, and we reviewed these and we categorized them. And then we used the NIH research condition and disease categorization system, or which we call the RCDC system. And we sort of categorized and looked. We included things that were definite neurological diseases and then things that were highly linked to neurological diseases such as hypertension. And we put these together. We debated on this, but we used non-Hispanic white as the reference. But I'll mention one of the interesting findings that we found. And so when you look through this time period, you can see that there, in terms of the take-home points, the mortality rates from neurological diseases, that they have started to increase during this decade, and not just related to the pandemic. The death rates from neurological diseases, that they're higher for non-Hispanic Black Americans compared to non-Hispanic white population. Now, the other interesting thing, when you look at the blue line, I don't know if you can see my arrow with this blue line here under the non-Hispanic Black population is here, and we can see that there's this sustained difference, but there are other groups that actually have lower mortality rates from neurological disorders than the non-Hispanic white population. And so this is why this concept of health equity, we want to achieve the highest or the lowest mortality rate or the highest level of health for everyone in society. And so our non-Hispanic, Asian American, Hawaiian population actually have the lowest rate here. This, at the NIH, we've been thinking about looking at the subgroup populations. Oftentimes when we think of Asian Americans, we lump people together, and we know that that's a large group of people. And so there are disparities that are missed when we lump groups together. But just sort of looking general, we see this difference. And so we chose not to use Asian Americans because a priori, we said that we would do non-Hispanic whites. And so during this period, what we found during this 10-year period, that there was an excess of nearly 30,000 deaths that took place for non-Hispanic Black populations. And we said that this was due to the health inequities that we have there. And so that's very important. So that was sort of one of the findings that we got. I also worked with the American Academy of Neurology on one of their work groups. And so the registries committee, sorry, my phone just started ringing like right in the middle. It's in a different room. But in any case, I am on the registries committee. And so we also wanted to look at the registry committee data. And for those of you that aren't aware, the registry database is it's a sort of a real time database of how outpatient clinical neurology is practiced throughout the country. And so information from large academic institutions, private practices, other groups is either pushed or pulled to a database and coordinated through the AAN, and it has quality metrics associated with it. And so we wanted to look at that data and see if there are any disparities in that data. And so we, in 2022, we presented this as an abstract to the at the AAN. And so our article was published actually last month in Neurology Clinical Practice. And what we found was that there's a lot of missing data in the EHR and also incomplete data when it comes to race and ethnicity. And so if you truly want to address health equity, then we need to know race and ethnicity. This is something that could be a little sensitive to people. And so we actually are working with the AAN as well to develop a position paper on with clear examples of how neurology practices can actually address this issue of missing race and ethnic data in terms of training front office staff, in terms of the importance of this, training people how to have these types of conversations with people in terms of why it's important to collect the race and ethnicity data, and to try to distinguish between someone that does not, if a variable is missing because someone chose not to give the information versus someone not putting in the data in terms of unknown or not wanting to give the information. And so that's something you'll hear more about, but this is something else that we have to address. If we want to be able to address health equity, we have to have this data in order to be able to collect it. One of the other things that we did was the group, one of the subgroups put together a health equity framework. And so what they found, and this was the group of experts that do work related to social determinants of health and interventions and other things related to neurological disorders. And they concluded from doing a literature review that the primary determinants of inequities in neurological disorders and stroke are structural and social determinants of health, related to structural and social determinants of health, and not biologic factors. Historically, a lot of research focused on looking at biologic differences to explain some of the disparities that we see in neurological disorders, particularly like stroke. But what we now know is that these structural and social determinants are very important and more important, and that there are multiple modifiable mechanisms and pathways there linking these factors with these negative neurological outcomes. The other point is that racism is an important conceptual tool to explain the existence of these persistent health inequities. And again, if you look at, you think of that excess mortality diagram, the Black-white difference was consistent throughout the 10-year period that we looked at. And that efforts to achieve inequity should consider and address racism as well as these structural and social determinants of health. And so we actually created a novel and unique neurological disease health equity framework that I see here. This is going to be in one of the publications, and we'd like for researchers to consider this in the future. And so there are a lot of factors beyond the biologic. I don't know if you can see my arrow, but we have the biologic conditions here, but there's the structural determinants of health that are important, such as structural racism, violence, discrimination, policies that impact health. Also, social determinants of health, education, occupation, income, gender, class, and the socioeconomic position, the healthcare system, and all of these other factors here. So this is another factor here. And then one of the other groups actually focused on communication and dissemination of information to the public. And so this is big. And so we felt that facilitation and widespread dissemination of our study findings, particularly to diverse communities, is very important in order to get diverse communities to understand risk for disease and treatments and other things, particularly where there's evidence-based research showing a benefit. And with this, we have to promote the engagement of diverse communities as well as promote information related to training of diverse communications and training people and how to communicate information to diverse populations as well. And so with this in mind, I'm going to end with this, and someone let me know how we are with time. I'm going to try to go through these a little quickly. We have a campaign that we started with geared directly to African-American and men based upon the SPRINT study and the SPRINT Mind study. The SPRINT looked at moderate versus tight control of blood pressure. And that was a blood pressure level less than 140/90 versus 120/80. And what it found was that we had fewer cardiovascular disease in people that had that tight control less than 120/80. And so that's sort of the blood pressure parameter that's suggested. But the study had a sub-study called Sprint Mind that found that people who had uncontrolled high blood pressure in midlife, and we designate midlife as 28 to 45, that they had higher rates of cognitive impairment later in life and dementia. And so because of the high rates of hypertension, 1 in every 3 adults and 1 in every 2 African-American adults have high blood pressure. And when you think of uncontrolled hypertension, the group in the country with the highest rate of uncontrolled hypertension is African-American men. So in order to address that specific high-risk population, we developed a public health campaign geared directly to African-American men. And so this, I've been working with various groups to implement this with our communications department throughout the country. And so just some of the slides, if I'm giving a talk, I've done webinars and other things, and I'm not going to go through this because of time, but I sort of talk about these factors related to stroke. I'm a vascular neurologist. That's sort of my background. And then talk about, so I'm going to jump through these. So the vascular neurology people on this webinar, I'm sure you can relate to this. So we have, these are the things that we want to prevent, these large vessel occlusions and of the dominant hemisphere that are very devastating, these really large strokes that can be incompatible with life. And so we talked to them about that in the early warning signs. I list here, there's a documentary that I participated in and was the neurology expert in called A Teachable Moment. It's on Amazon Prime. So I don't know if you all have been able to see it yet. It's won some film festival awards, but this is something that's very good for the public. It highlights 4 people in the greater Washington, D.C. area that suffered strokes and their various situations that they deal with related to that, but very instructional as well. And then we talk about risk factors, non-modifiable and modifiable risk factors, and high blood pressure being the number one modifiable risk factor for high blood pressure, and how this how it differentially impacts certain groups. And then the impact of uncontrolled hypertension on the various organs in the body, including the brain. And then we talk about and actually show these MRI images to people in the community. And this has been pretty compelling for people in terms of the nonspecific white matter changes that we see in people with chronic uncontrolled hypertension and how that's related to cognitive impairment. We had a focus group of over 30 people, several different focus groups with an average of 20 to 30 people, that we tested certain campaigns and certain taglines to see what would get people to change their behavior and this information. We have it on the Mind Your Risk website. And so I have it here listed on the slide, mindyourrisk.nih.gov. If you go to that website, you can see some of this information. But one of our taglines is, you have a powerful mind, don't risk losing it to high blood pressure. That was one that sort of worked well. And the other one was, nobody can lower your risk of stroke and dementia like you. And then these images of active individuals and exercising. And these were images and taglines that seemed to motivate our demographic population to make changes in their behavior. We also have on our website information listing the various modifiable risk factors for people, how to modify them. We talk about self-monitoring of blood pressure. We know that people that self-monitor their blood pressure actually have better control of their blood pressure as well. And we have tools where people can log this information, write it down, or either save it electronically and share it with their primary care provider in order to work together collaboratively in order to get the blood pressure under better control. So I have that listed here on these particular slides. This is a video. I'm not going to try to play this now, but we've created a nice educational video where it just shows active people and how you can maintain your physical activity in order to lower your risk of the long-term complications of high blood pressure. Well, looks, can someone let me know if you can hear this or not? If not, I'll go.
We can hear it.
I'ma do some things that live a life that I'm supposed to live. Wake up as the sun is rising and give thanks again. This summer is a new day dawning. Hold on, it's a new day coming.
Okay. And so, as I mentioned, I've had several webinars with people from when we partner with Radio One, which is one of the largest sort of urban radio stations in the country. We've done some work in the Atlanta area and Washington, D.C. and Chicago and other areas as well, sort of marketing this public health campaign. And just from last year, we're going to do some more market research related to this. But as of last year, you can see June is Men's Health Month. And so we piloted this last year, and we saw an increase in users of our website, the Mind Your Risk website, as well as page viewers as well. And we actually asked people, we did another small project to ask people what they felt about this information and how it caused them to change their behavior. One of the things people felt that their knowledge was increased the most in terms of the understanding dementia and the connection between dementia and uncontrolled hypertension. And so they felt that that what we were doing was working and that we should continue to do that as well. I know I went quickly through some of the last slides. These are people in my office. As Carolina mentioned, we do have some open positions. I do have an open position in my office as well for a global health person. So if you go to our website and look at that, Dr. Sharice Sankor will be speaking to you all in June in person. You'll hear more about this. This is our HUE, our Health Equity Work Group. And so it's taken a lot of us across the Institute to do some of the work that we're doing. And I thank you all. I'm going to stop sharing now. I'll see where we are from time and take any questions.
I don't see any questions in the chat or the Q&A. Please feel free to raise your hand if you would like permission to talk.
And I know this was a teaser, and both Carolina and myself, we went quickly through this. And so I will share my slides with Courtney, and so you guys can look at that. And then please feel free to email us if you have any questions too. I see a hand up.
Thank you both for really helpful talks. I just had a question in terms of I think with the common data elements you mentioned that for preclinical or early clinical, it can be pretty challenging. And I just was wondering, and also I think with making sure that in sort of earlier or smaller trials, that sometimes the equity and inclusion is, it's harder to meet goals that would actually come up with a much more representative group of participants early on. And I just was wondering if you had any suggestions about that. I know it's sort of a big question.
Well, I can start. I mean, I think one of the things that came out of our strategic planning process, and I didn't put these slides and talk about this, but I'm sure Sharice will talk about it, is the need for community engagement. And so you'll hear a lot more about this. And so we are starting to implement some of the things that we found, but it's important, number one, to know the frequency, if known, the frequency of the disease in the particular population, like we know the clear disparities in stroke outcomes from several studies. And so if there's a stroke study, then the demographic populations at risk, it's important to include that population. However, there are a lot of areas in neurology where we're not sure of the demographic distribution and the epidemiology of the disease with certain populations. And so it's hard. And so it's important to know your population. Health equity is important. And so if you service a population that's diverse, it's important to reach out to and to engage the community surrounding your institutions or that you serve that are from diverse backgrounds, and you have to develop unique ways for the various communities, because not all messages are the same, as we showed, and hopefully I showed that with our One Public Health campaign. So the way you outreach to one community may be different from how you outreach to another community. And if we don't know the demographic distribution of the disease, then what we think is to just think in terms of the demographic distribution of the country, and consider that as being sort of a standard to make sure that you do have representation of people from different backgrounds. The other piece, and now Carolina can jump in, the other piece too is it's important to have a diverse team, which came out as well. So make sure that the members of your research team, the NIH Brain Initiative has a nice plan for the enhancement of diverse perspectives. We call that the PEDP, and you can find that on the Brain website. If you put NIH Brain, you can get it, or PEDP, plan to enhance diverse perspectives. And part of that is making sure that in order to do that, you have to have a diverse research team, people that reflect and look like the people in the population that you're trying to enroll. And so those are some points that I'll start with. And Carolina, you can talk about the common data elements.
Okay, so the preclinical CDs, they're, I think in many areas are inexistent. And I think that one of the NIH is working on some of them. We're preparing some things at NINDS, but only in a limited area. So I think the best advice that I have is communities or different groups of scientists should get together and start working on, having a consensus in how to collect that type of data, and also reach out to funding agencies. So feel free to email me. I can't promise that we'll have something, but I can just talk to other institutes to see if they have anything in the area that you're interested in, or any other projects that are not NIH funded.
Thank you both.
Thank you for that question. And please feel free, anyone, we still have a couple more minutes if anyone has any question. I say the only silly question is the unasked question. So if you have anything that you're thinking, please ask.
We don't have any questions, and we only have 1 more minute, and I think the siren people, including me, have to jump to our next siren meeting at 1.
Well, thank you both very much. We really appreciate your time and presentations today, and thank you all for joining us. This recording will be posted on the website, and I will distribute the slides as well. So thank you both again. You guys have a great afternoon.
Thank you.
Thank you. Bye-bye.
Bye.